Now, I must confess that I was snooping on you guys talking before we turned the cameras on. And there was some discussion as to whether the relapses may be less common versus we're starting with less severe disease to begin with because our detection capability is easier, better. So if we'd been able to detect disease that early in a previous patient cohort, maybe that too would have had fewer relapses. Where does that all fit?
Well, it's really extraordinarily striking that if you look at the attack rate from the pivotal trials in an untreated era, they're way higher than they are in the current era trials. It's striking, even when you look at placebo arms. So it almost seems as if we're entering into our modern era clinical trials less active relapsing MS. What's the explanation for that? Well, we're in a treatment era now. Some people have said we're cherry picking off the most active patients. We're putting them on treatment, not waiting to have them go into a trial. It's also feasible, possible, perhaps most provocative, that perhaps the nature of MS is changing to be less active. We're certainly able to make the diagnosis earlier. We're even treating at the first attack, and we have at least 7 phase 3 trials that document the benefits of the disease-modifying therapies. So we are seeing less relapses in the modern era.
I mean, this is fascinating. Just as we're beginning to treat the disease is changing on us. Maybe. Doesn't mean the treatments shouldn't be used. I think that's fair to say.
I think MS is the major success story in neurology. It's the only major disease where we've developed multiple disease-modifying therapies, and we are changing the face of this disease. So it's a wonderful success story for us.
So which patients, I'll put you on the spot, which patients are the most likely to benefit from disease-modifying therapies?
Well, I can give you my own. I'm sure everybody
Well, that's
will
why
have
you're
a
here.
different
Please give me
opinion.
your own.
Okay. The major form of MS is the relapsing, attacking form of MS. All of our disease-modifying therapies have been documented to help relapsing, attacking MS. My own belief is every patient that has relapsing MS should be offered and encouraged to go on a disease-modifying therapy as soon as possible. I think there is a window of opportunity. I think the earlier treatment is critical. And if you extrapolate from rheumatoid arthritis, where they have guidelines for treatment, we're lacking them, unfortunately, the first 3 to 6 months may be a critical time period to get a patient on an effective therapy early to minimize and to maximize their benefit and minimize later injury.
Do you all agree with that? You get one symptom, one attack, boom, start treating?
I mean, I do. I think that the whole field has moved in that direction over the past decade. I think that's become really the standard of care on the back of all of those successful trials. I think we recognize that if we're going to treat every patient with a first attack, we're probably over-treating some people. We're probably over-treating some patients that might not have been destined to go on and have multiple attacks and multiple relapses, and I think that's okay at this point in time, particularly for the agents that we have that we know are safe, that have a long track record where we're not exposing people to significant risks.
Right.
I think it's okay to overtreat a little bit. It has moved our field forward by doing that.
I mean, I'll just be the curmudgeon here for a second. There's no medication I know of that's absolutely safe. And if a cohort of these patients will never have another attack, aren't you subjecting a cohort to side effects they might not otherwise have had?
Yeah, so as Stephen has said, there may be a small percentage of people whose untreated disease course would have been relatively benign. And we know this historically, that there are people who have been characterized, depending on how the definitions are laid out, have a mild or benign form of MS. But the majority don't. And we really don't, at this point, know how to prognosticate accurately enough at the beginning of the disease course or when they're diagnosed, which is not necessarily the exact same time. But in any case, we don't know when they first come to our attention. We don't know how to prognosticate accurately. So as Stephen has said, we have a number of treatments for 15 or 20 years that have a very good track record of safety. They're not without some side effects, of course, but safety track record, really devoid of major complications in almost every case. And so we do think it makes sense, basically what Pat Coyle was just alluding to begin people at the earliest phase of the disease once we identify it as relapsing in nature.
You know what this sounds like to me? It sounds like the discussions the cardiologists had, 10 or 15 years ago, about putting everybody on aspirin. Yeah, there are some side effects, but you know, it's a great drug and pretty safe.
Well, you know, I think as opposed to that, which is sort of almost a public health campaign, I think what we have here is real consistency in the clinical trials of patients with their first MS attack. That the placebo groups, to go back to that idea again, gives us a window into what would happen to these patients if they were untreated. And even though these trials are relatively short, 2 years typically, the placebo groups in all of these clinically isolated syndrome trials, all of them have about 85% of those patients have new disease activity, at least as seen on MRI, within 2 years. Incredible consistency. The benefit trial, the precise trial, the reflex trial, all the placebo groups really do the same. And it tells us that if 85% are going to have new MS disease activity in 2 years, it's going to be even higher in 5 years, in 10 years, or over the lifespan of these patients.
So what we know about this disease is, unfortunately for patients left to its own devices, it keeps going. So how do you